When my sister and I were little, and my dad would sometimes disappear for a few weeks, or at one point, when I was in third grade, a year at one fell swoop, nothing was said. My mom and dad had been really under doctor's orders with the stipulation, never tell children about mental illness they can't understand.
Like many people who get this illness, I mean, the average age of onset is about 17, 18, and I got hit exactly at 17. And I had really been pretty normal until that point. I certainly had no problems, lots of friends, lots of love of school and life, and never been depressed a day in my life, and everything was great and fabulous, and then my world fell apart.
People with abnormalities, with psychiatric abnormalities, are just exaggerations of stuff that we all experience. Anxiety is a perfectly good example of that. Many of us are uncomfortable in certain social circumstances. Some of us are fine, no problem at all. Some of us are really so nervous that they can't do it, and some people won't. If they have to go to a party, will stay home. And so there's a wide spectrum within any behavior, and the line between normality and abnormality is one that is kind of blurry.
Of course, one factor to take into consideration is just the basic statistical frequency of a behavior, our set of behaviors. So behavior that's very unusual outside of the norm could potentially fall in the category of abnormal behavior, but that's just one dimension that's considered.
If it gets in the way of a person's social, occupational functioning, then we're much more likely to put in the category of disorder and to target it for treatment.
We're talking about unusual behavior that's dysfunctional, that gets the individual into trouble in life.
When I first came home from college for Christmas break, spring break, and my dad pulled me into his study at home and began to talk to me about what it was like to be 16 years of age in the 30s. And my dad said I began to worry and worry so much I couldn't sleep. And he talked about wandering the streets of Pasadena, climbing up to the roof of the home and jumping with the belief he could fly, and that this would send a message. You must stop Hitler and must stop Mussolini.
I was sort of mildly manic, but I wasn't certainly aware of that. I just felt great. I was zooming around and had a lot of ideas, wearing my friends out, not wearing myself out, unfortunately. Thought I had kind of the clues of the universe, but it wasn't over the top by any stretch of the imagination. And then I got profoundly psychotically depressed. I could scarcely get out of bed in the morning. I had no energy, which was extremely unusual. I always had lots of energy. I had no interest in anything. Everything was bleak and decaying and pointless. I started thinking about suicide. Never thought about suicide in my life. Started thinking about ways of killing myself. I was delusional. I was very, very, very sick.
Prior to the time that we had any label for any mental illness, all abnormal behavior was perceived from the perspective of religion. Obviously, with time, there's gradually been an increase in the acceptance of more biological notions about the determinants of abnormal behavior. And today, in the case of serious mental disorders, most everyone in the field believes that they involve both biological and psychosocial environmental components.
There are disorders that are more likely to be male-linked or female-linked. And when I say linked, it's not clear of why, how much, whether it's societal pressures or whether it's something else. You take something like panic disorder and agoraphobic avoidance. As you go toward the more extreme ends of avoidance, you tend to get higher ratios of women than men.
There are many, many different factors that come together to lead a person to develop a serious mental illness. People are complicated, disorders are complicated. And it's true in psychiatry, but it's also true in the rest of medicine.
In an attempt to uncomplicate this state of affairs, the psychiatry profession has created a mechanism for classifying psychological disorders, a work in progress referred to as DSM.
Current edition of the American Psychiatric Association's Diagnostic and Statistical Manual for Psychiatric Disorders uses more behavioral definitions that enable mental health workers to diagnose people with greater reliability than what used to be the case.
Why bother to group and make categories? It aids communication. It aids research, that we can then say we have an idea of this syndrome that tends to hang together, and so we can bring into studies people who have that syndrome, learn about it, look at treatment, and then convey information. So despite those uses, though, there's this sense that we have drawn some artificial lines around a continuum of where sadness goes into the syndrome of depression. And what we've used is a symptom count. Once you get this many symptoms that hang together at the same time, and the distress and disability that gets in the way of your life, we're willing to put into a category, even though we know that we're making a category out of what is probably a continuum.
What starts to emerge from the field of affective neuroscience is that potentially by interrogating brain circuitry in the brain, we might be able to basically develop a different way of categorizing psychiatric disorders. For instance, patients with depression, although they may receive the same diagnosis, may have completely different symptoms profiles. And the potential implication for treatment might be very important. And therefore, if we one day will be able to characterize basically dysfunction in the brain among these different patients.
Some people are concerned about the negative fallout that may result from such labeling.
And one of the problems that we have is that the diagnoses for mental illness show certain kinds of biases. For example, African Americans are disproportionately diagnosed as schizophrenic relative to whites. Affective disorders or bipolar disorders is the reverse. African Americans tend to be underdiagnosed for bipolar disorders, and European Americans are more highly diagnosed. So is that because the incidences are different, or because they're looking at different things, or they're not taking into account relevant cultural aspects? We don't really know, and I think a lot of research is going on trying to explore that.
The major struggle that we face in psychiatry is, I suppose, overcoming the stigma associated with mental illness.
When do you tell somebody that you're going out with that you have a major psychiatric illness and that you're taking drugs for it? It's harder, I think, with schizophrenia and bipolar illness, where you're really talking about illnesses that have the potential of a lot of strange, bizarre behaviors, potentially violent behaviors, and very frightening to people. So that issue is much more of a real one. But it's also professional repercussions. If you're a teacher or a lawyer or a secretary, or if you work in a hospital setting like I do, or you have licenses to practice whatever you practice, they're very real issues.
One is that patients don't want to come in for treatment. They feel that they're being labeled. They feel that their coworkers, their friends, or their family will think less of them if they say, I have a problem for which I need help. But again, all of these illnesses are not weaknesses. They are, in fact, illnesses that need specific treatment.
In this episode and the next, we will look at 4 major categories of psychological disorders: anxiety disorders, personality disorders, mood disorders, and schizophrenia. We begin with anxiety disorders and its many variations.
I start off teaching people what anxiety is and where it comes from in the first place by telling them, look, fear and anxiety is part of the normal human condition. We have evolved as a species to be scaredy cats. So there's a small group of people either by virtue of their DNA or because of traumatic experiences they've had, they end up with anxiety disorders because their normal functioning alarm system, the thing in their body that protects them from danger, starts malfunctioning. Kind of like having a burglar alarm system in your house where the bell keeps going off even though there are no burglars there. That's what an anxiety disorder is.
And in the anxiety disorders, which includes phobias, generalized anxiety disorder, social phobias, panic disorder, agoraphobia, obsessive-compulsive disorder, and post-traumatic stress disorder, what we see is a combination of fear/panic and anxiety. Some of the anxiety disorders are characterized more by fear, and some are characterized more by anxiety, but they often co-occur in the different anxiety disorders in differing combinations.
Generalized anxiety disorder is chronic worry about a number of life events in excess of what appears normal. That's what helps differentiate it from problem solving or seeming problem solving. The worry itself gets difficult to control, takes on a life of its own, and no longer has an adaptive function. A panic attack itself is this rapid mobilization of the fight or flight fear response, where suddenly my heart would be pounding, I may have numbness and tingling, it may be hard to focus on your face, mouth may go dry. The core fear is of what's happening in my body.
It is essentially the response that people experience when they're hiking on a mountain trail and a bear starts running after them. And a panic attack is essentially the exact same thing when there is no bear there.
And I feel like I can't function, and I may feel like I'm going crazy, I'm about to lose control and have to run out of the room, or that I might be dying from a stroke, a heart attack. And you can imagine the sort of catastrophic thoughts.
People with panic disorder become so frightened of having another one that they become afraid of going into situations where one might happen. But even if they're not agoraphobic, they still develop apprehension about having another one because it's such an unpleasant experience.
Some dangers people face are without question real and may have repercussions.
Think of the essence of post-traumatic stress disorder, is that the person has gone through an event that is so severe that they become frightened of the memories and how the memories make them feel.
We were standing face to face. The gun was pointed point blank at me. And all of a sudden, Chuck rushed him from the side. I mean, just like a football tackle. He'd slammed him against the wall, and they were over there wrestling, and the right hand with the gun was coming up.
The hallmark symptoms of post-traumatic stress disorder that differentiate it really from almost every other psychiatric disorder are the intrusive re-experiencing of the event.
Somebody who reminds me of my attacker, or the time of day, or certain smells that might have been present. My emotional system will try to warn me that's happening again. In a primitive way, how does it warn me? It brings up memories of the attack.
I'd wake up in the morning and I'd just pull the sheets over my head. I didn't want to go out. I didn't want to get cleaned up, dressed up, talk to anybody, listen to anybody, be confronted by anything.
Nightmares, intrusive thoughts, pictures that just pop into your head of the scene or what happened to you. The second kind of psychological or emotional experience has to do with avoidance, a swinging back and forth between, yep, it happened, and no, this can't possibly have happened. And the intrusion delivers the first message, and the avoidance and numbing is associated with the second message.
But not everyone who experiences a traumatic event will develop PTSD.
What we found was that the level of psychological preparedness was the single best predictor of who developed post-traumatic stress disorder among 10 other predictor variables. the idea of having control when a trauma is happening and how much that's going to affect how much fear is acquired. Not all torture survivors develop PTSD. Not all earthquake victims develop PTSD. Not all hurricane victims develop PTSD. Some do, some don't. And I'm sure they're temperamental variables, they're prior experience variables, but one of these variables may have something to do with their psychological preparedness in a more general way.
Another factor, tragically I guess you would say, is having been exposed previously to other traumatic events, modified by whether that prior exposure generated some kind of symptomatic response. And so I think one way of thinking about it is as like a weak knee. When you're playing basketball, you twist your knee, it hurts a little bit, doesn't stop you from playing, you play, the next time same thing happens, then you're out.
Many, many people are very frightened by public speaking, and they go to great lengths to avoid ever having to speak in public. But there are other people called generalized social phobics who actually are frightened of most social situations. Not only do they not want to speak in public, they don't want to go to parties, they don't want to eat in a restaurant, they don't want to sign a check in public.
A number of current conceptualizations suggest that it's a sense of social cost. Should I make a mistake while talking to you? Should I flub my sentence? How bad would that be? And can I recover from it? That's a sense of social cost.
Obsessive-compulsive disorder is a condition in which people experience recurrent, unwanted, obsessive thoughts or images that they find intrusive and very disturbing. And this is usually associated with compulsive rituals that are somehow designed to neutralize the obsessive thoughts and images. So, for example, someone might be obsessed with cleanliness and have all these images of dirt and disease that come to them, and they develop this urge to go wash their hands.
I don't want to take these germs home and kill my kid might be the true concern. But later in the disorder, you don't even have that thought. It just feels dangerous. Logically, I know I'm washing. I know I've washed for 5 minutes. I know I've washed for 10 minutes. But there's the emotional sense that I've washed enough. Click. It's there. I'm safe again. And these things tend to progress.
And they go wash their hands not for 2 minutes or for 5 minutes, but for 20 minutes, 30 minutes, an hour. In extreme cases, they may start using abrasive cleansers to clean their hands.
Now, the critical thing to understand about obsessive-compulsive disorder, which clearly differentiates it from other conditions where people get these kinds of thoughts and urges, is that in obsessive-compulsive disorder, being a truly neuropsychiatric condition, the people really do experience the intrusive thoughts and urges as nonsensical, as not being them in any meaningful sense. Why am I having this thought? And especially, why doesn't this thought go away?
So if you image people's brains who have OCD, you could see the circuits that are overactive in this disorder. Part of the basal ganglia, part of the frontal cortex.
And that group of structures comprises an automatic transmission in the brain that's really responsible for a lot of the extremely efficient, unconscious actions that we take during the day. In obsessive-compulsive disorder, those error detection messages get stuck in gear. That's why I came up with this term brain lock, because the brain itself is stuck in gear and this error detection message keeps coming in again and again and again and again in an extremely bothersome, repetitive way.
Researchers link anxiety disorders with classical conditioning of fear as well.
The other thing about anxiety disorders that's particularly noteworthy is that they tend to be chronic. They don't tend to go away unless treated. That is not to say that they don't fluctuate in intensity over time, but they don't tend to go away and stay away for a while, as they do with something like major depression.
People with various anxiety disorders, social anxiety disorder or phobia actually show increased activity in the amygdala and associated regions. Another example in neuroimaging research is the use of electroencephalography, which records brain waves non-invasively from a participant. Here again, a researcher have found that very early, even before concept or information reach the level of conscious awareness, we can see some dysfunctional activity in the brain in people with anxiety disorders.
This over-arousal of brain regions known to react to potential danger is common to several disorders.
Many people with one anxiety disorder will have more than one anxiety disorder, either concurrently or at some point in their lives. And many people with an anxiety disorder will also have a mood disorder, like major depression at some point or another. What is the reason why these disorders tend to co-occur? Neuroticism, which is one of the main personality variables, seems to be a common factor across the mood and anxiety disorders. People who are high in neuroticism tend to experience negative mood states readily and easily.
Personality itself can become distorted to the point that psychological dysfunction becomes tightly interwoven with an individual's patterns of behavior.
The personality disorders are identified by the fact that they are principally disorders of the self, and two, they are developmental in origin.
There are individuals in whom the biological starting point has led to long-term, repeated patterns of personality that cause them considerable distress or cause others considerable distress. So, in the former category, we have people who, say, are just avoidant and have real trouble dealing with other people, being in social situations. And then in that latter category, most notably, is what we colloquially call the con man. People, antisocial personality, who virtually have no conscience.
Just as in other major categories, there are a number of psychological illnesses that cluster around personality.
First of all, the narcissistic disorder, you don't have to be a therapist to diagnose it. It's the guy who you go to a cocktail party and he says, "Enough about me, let's talk about you. What do you think of my latest movie?" That's good. I got a call from this sports doctor, and he said, "I'm very interested in narcissism in sports." And I said, "You got a huge field there."
They're guys who have had scrapbooks that started when they were about 9 or 10 years old. They've been celebrities in their communities. They have such extraordinary athletic ability that it shows up very early on. The downside of that is that they've been treated very specially. They've had someone running in front, picking the rocks out of the road, the coaches making allowances for them.
It's so widespread that people get the idea that narcissism by itself is pathologic, which of course nothing could be further from the truth. There is no life without narcissism, healthy narcissism. And healthy narcissism means that you have a sense of self of being not grandiose, but competent, based on reality, and you are able to use your reality perception as a way of healthily maintaining your self-esteem.
In contrast, people with emotionless schizoid disorders find it difficult to relate to anyone at all.
That if he allows a relationship with the other, he will be totally overwhelmed. So that in order to protect himself, he sets up relationships of distance or no relationships at all, which then presents all kinds of other problems. I saw a patient who said he was up to be made CEO of the Corp. And he had a meeting with the current CEO and who said, "You really are one of the brightest people we have here. And the board wanted to appoint you to be the head."
I hired you because
the trouble is, your relationship with your workers is so bad, you can't do it. So he goes home and he says to his wife, do you know what happened to me today? This guy had the gall to say that my relationships were bad. And he went on and on. And his wife says, this doesn't surprise me at all. You have the same problem with me and the kids. So then he comes to see me. And he says, how can all these people be so wrong?
Most troubling is the antisocial personality disorder, a person whose lack of conscience can be glaringly apparent even before the age of 15.
Right after Columbine, I was down at the FBI Academy and I reviewed videotapes about the incident. And one segment of that included Harris and Klebold were seated in two chairs side by side facing the camera, talking about what they were going to do, who they were going to kill and why they were going to kill people. Then they took you on a tour of Harris's bedroom where they had on display the sawed-off shotgun and the bomb-making equipment, and there was a big coil of detonator cord hanging on the wall over his bed. They were particularly childish. They reminded you of little 8-year-olds showing off their G.I. Joe collection as they were doing this. But the parents and the father was former military. He would have recognized this stuff, but it was obvious they had never been in there. So again, these are kids who I think in many cases will train the parents that you better stay away, let me alone, or otherwise there will be real trouble.
What did they hope to achieve? Why did they do it?
Because it was fun. You know, it's kind of a shocking thing to say, but it gets the point across of what the motivation of a psychopath is. Psychopathic behavior is for their own manipulation and gain. I happen to think that since one of the ways we maintain and regulate our sense of well-being even is through these relationships with others, they don't have that. So I think that there is a void behind that. And to deal with the void, they try to charge it with excitement of some kind, one kind or another.
Do we have the range of personality disorders? And the assumption, of course, is that treatment will take longer because, I've been rehearsing this for a lifetime, and these changes feel like the core me. We're changing me.
And these are long-term, long-trend patterns that really stamp who you are.
They've been relatively ignored in research across the decades. They're getting more attention now, and we're trying to build treatment that works.
First place that you feel
the brain's being scanned right, left, and center, every mood conceivable. People are learning just an incredible amount about how the brain functions, under what circumstances it malfunctions. We know so much more about genetics. All the basics in the field are really quite remarkably different. It's just about as exciting as you get.
Inside Out is a 22-part series about psychology. For information on this program and accompanying materials, call 1-800-576-2988 or visit us online.